Today, we're seeing tremendous excitement about artificial intelligence in biomedicine, and I believe it's becoming clear that much of it focuses on making existing processes faster and more efficient. These improvements are quite valuable and necessary in many cases. For example, AI can help pathologists review slides more quickly, help radiologists detect lesions more accurately, and help clinicians process information more efficiently. These advances can reduce healthcare costs, minimize errors, and improve access to care. But I think if we limit ourselves to only making faster horses, we may miss opportunities for transformative change. As I recently argued in Clinical and Translational Science, nowhere is this more evident than in how we classify cancer, where efficiency alone won't solve a fundamental challenge. The fact that our 19th century approach to cancer classification is increasingly misaligned with our 21st century aspirations in precision medicine. I think the need for this transformation becomes quite clear when we look at treatment outcomes. In a study with the FDA, we analyzed 30 registrational clinical trials of non-small cell lung cancer from 2003 to 2017. Median survival improved dramatically from 9 months in 2003 to about 40 months by 2017. For patients with specific molecular alterations like EGFR mutations, targeted therapies have pushed survival beyond 3 years, as many of us know in many cases. This is amazing progress that we should all be proud of as a community. To understand this progress not from an abstract statistical concept such as PFS, but from a more patient-centric perspective, we analyzed the number needed to benefit, which tells us how many patients we need to treat in order to help one additional patient. In 2003, we needed to treat 8 patients to benefit 1. By 2017, in biomarker-selected patients, that number dropped to about 3 patients. Looking at the numbers this way reveals a sobering reality. Even with our most potent targeted therapies, we still need to treat 3 patients to benefit 1. This means that more than half of patients receive treatment without deriving meaningful clinical benefit, highlighting how far we remain from precision medicine's goal of matching the right therapy to the right patient. Precision medicine, as we know, postulates that giving the right therapy at the right dose and intensity at the right time to the right patient should theoretically result in a 100% response rate. I believe we often fall short of this ideal not because the framework is flawed, but because we can't always identify the right patients using our current cancer classification systems, something that we try to correct with predictive biomarkers with varying degrees of success. Our traditional approach to cancer classification, based primarily on anatomical location and histological features observed through microscopy, is a historical artifact that increasingly constrains our ability to match the right therapy to the right patient. I think this isn't just a theoretical issue. In fact, if we look at clinical trials, we'll notice that they consistently reveal heterogeneous populations with varying degrees of clinical benefit in nearly all studies, with many patients unfortunately deriving minimal benefit. Recent work from the U.S. National Cancer Institute's Human Tumor Atlas Network shows why traditional classifications fall short. Their analysis of 131 tumor samples using spatial transcriptomics, single nucleus RNA sequencing, and multiplex imaging revealed distinct microregions, which are essentially spatially organized clusters of cancer cells with unique genetic signatures and varying levels of oncogenic activity. These microregions within the same tumor behave quite differently in primary versus metastatic sites and show distinct patterns of treatment response and resistance. Now, traditional microscopic examination, no matter how automated, simply cannot capture this complexity. This is where I think AI could catalyze a genuine transformation. Rather than just automating or enhancing existing workflows, AI could help us integrate multiple data modalities, create classification systems that actually reflect cancer's true biological complexity at the individual patient level. 2 tumors that look identical under a microscope might have fundamentally different architectures that determine their behavior and treatment response. I believe the implications of a new cancer classification schema are quite profound. Instead of starting with anatomy, broad anatomical categories, and working our way down, we need to build up from the molecular and cellular level to create more meaningful disease taxonomies. This would help us better predict which patients will respond to specific treatments, design more effective therapeutic strategies, and understand why some cancers become resistant to therapy. What I'm really excited about is the fact that the building blocks for this transformation are already in place. Our biological understanding of disease is advancing at an extraordinary pace, matched by rapidly expanding computational capabilities. I believe we're at an ideal inflection point to not only drive greater efficiencies in workflows, but to fundamentally shift how we think about the nature of the challenge that is cancer itself. By developing AI-driven analyses that capture the true complexity of cancer, we can finally deliver on the transformative promise of precision medicine.